So I'd like to introduce our wonderful speaker today, Dr. Velázquez Mañana. Dr. Velázquez Mañana received her medical degree from the University of Puerto Rico School of Medicine in Puerto Rico, followed by her internal medicine residency at Mount Sinai Beth Israel in New York, where she was also the chief resident. This was followed by our luck with her joining us here at UCSF as a hematology oncology fellow. She's currently a clinical instructor in the Division of Hematology Oncology at UCSF and holds a role as the postdoctoral research fellow at the University UCSF National Clinical Clinician Scholars Program. She aims to support and improve the outcomes of patients with lung cancer from vulnerable backgrounds using health services and disparities research, and is a major advocate for workforce diversity and gender equity. So our outline for today's session in What Happens After is we'll start with this intro for about 5 minutes, followed by the lecture by Dr. Velázquez Mañana on surveillance and survivorship, and we'll end this with our interactive Q&A with all of you. With that, I'd like to hand you to my colleague and friend, Dr. Velázquez Mañana, to discuss with us what happens after.
Well, welcome everyone, and thank you so much for joining us tonight. It's definitely a pleasure to be able to talk to all of you, and we are going to, over the next hour, do a whirlwind tour about what is survivorship care and what really happens after a cancer treatment and diagnosis. And a lot of the subjects that I am going to speak about today, we're going to cover relatively superficially for the amount of data and of knowledge that we have. We could do a whole series of weekly sessions just on survivorship care, and we're trying to consolidate everything in one specific hour. So we'll start by what is actually and who is a cancer survivor. And this is a subject that, like I said, there's a huge body of research and data behind. And the definition of who's a survivor is actually controversial because in reality, a cancer survivor is any person who has had a diagnosis of cancer. Most people, or historically the term had been used to identify those who had completed treatment for cancer and who were either on remission or cured, but they use in that way of the actual term, actually it's exclusionary. And everybody who lives and has been diagnosed with a diagnosis of cancer is considered a survivor by all of our guidelines and in national societies. And there are many types of survivors, including, like I said, those who currently have active cancer, who have been just diagnosed, who are undergoing treatment, or those who are free of cancer. And like I said, this term may or may not resonate with certain individuals, but we'll use it throughout the lecture to refer to this spectrum after a cancer diagnosis and to the group of patients who have been diagnosed with cancer at some point and stage. So survivorship care as a field really reflects the care that we give patients throughout the cancer journey, even from before you are diagnosed with cancer, regarding what are some risk factors that can increase risk of cancer, from to diagnosis, to providing supportive care during treatment, and here again referring to that survivorship stage once patients have completed treatment, what are things that we need to be in the lookout for and monitoring, and includes all the way into palliative care and end of life. And there is really, it's a field that has been ongoing for at least 20 years, and that has changed quite a bit over time. Initially, at the beginnings of what survivorship was as a field, we focused a lot on specifically looking at what is every single need that a patient with cancer could have and trying to address all of them. And that led to overwhelming people with tons of referrals and tons of information. And we've really learned and are continuing to learn more and more, trying to move from that cookie cutter approach in which it fits everyone to something that is very personalized and that is specific to each individual, because we as humans, all of us are going to have different needs, and every person is going to have different reactions to treatment, different specific complications that may, or long-term effects that they may have or not, and different priorities. And what those are regarding your priorities, and similarly, the specific side effects or issues that may be the most important to a person over time can change. So we want to make sure that as a field, we are taking into consideration how changes occur and how much needs vary along the process and the lifespan of people, and similarly how they're individualized from person to person. So how big of an issue is survivorship care in cancer survivors? It is a growing in population as we get better and better with trying to identify cancer at earlier stages and coming up with better treatments. We have had a lot of advances on different types of treatments, and how we treat cancer depends and varies quite significantly depending on the cancer type. And as we move further in the field and continue to do investigations, patients hopefully will continue to live longer and longer, which means that patients who are considered cancer survivors and who can potentially have long-term effects and different issues that are affecting them after a diagnosis of cancer will continue to grow. As of 2020, it's estimated that there's almost 17 million survivors of cancer in the United States. And this is only in the United States, not accounting the rest of the world. So we're talking about millions of people who have received different kinds of care and who have specific needs after being receiving treatment for cancer, which are approximately 5% of the US population. And as you can see on this graph, it's really showing the numbers in millions about how they're increasing over time from 1977 to 2022. The colors represent the years that people are living after a cancer diagnosis. And I'm glad to see that, you know, this yellow and blue parts of the bar graphs are actually increasing as we get better with specific treatments. So the number of people who are living longer after being diagnosed or treated for cancer is increasing, and are a large proportion of what the patients that we see or treat during survivorship care are. Who have very different needs than what people may go through right after a cancer diagnosis. And this number is only going to continue to grow. These are some projections that were done looking at specifically, if we continue at the current rates, how many cancer survivors we're expected to see. And by 2040, we're expected to see at least 26 million cancer survivors. So again, a huge need for continuing to understand what are the needs of patients, how could we address and support them. And the number of specific survivors really varies by what sites and what types of cancer there is. So the most common cancers, as you may have heard in the past, that affect us as humans are breast cancer and prostate cancer. And those, as you can see here, are the left two green bars in this chart, account for the large majority of patients who are on the survivor stage and have completed treatment on the United States. And it's not surprising because, as we know, similarly with colon cancer, which is the third one there, and gynecologic malignancies, people are routinely screened for breast cancer with mammograms, for colon cancer with colonoscopies. Cervical cancer screening is again recommended and part of preventive and primary care. So we expect to see those diagnoses being in larger numbers, and at the similar time having hopefully earlier and earlier diagnosis in earlier stages that we can treat with multimodal therapy, we can cure and get people to live longer. Among women and female survivors, it's estimated that breast cancer accounts for around 44% of women. And then the second and third more common in around 10% are uterine and colon cancers, followed by other more rare cancers. And among men, the most common as seen here is prostate, which is 45% of men, so almost half, followed by colon cancer, and then melanoma. And who are cancer survivors in terms of demographics? And this pie chart really shows you what the age distribution is for people. And as you can see, almost 70+% of cancer survivors are age 60 and older. Less than 40% are young individuals, and that really matters because we need to tailor how aggressive we're going to be with care, with interventions, what types of issues patients have after chemotherapy and treatment, depending specifically also on their age. And we have to think of what other comorbidities and other illnesses people may have that are common in certain age ranges and that you may experience as we get older. So to give a little bit of historical context and to kind of set the stage about what we're going to talk about, I mentioned earlier that that's really the field of cancer survivorship is something that is around 20 years old or a little bit more. And once it started, one of the big institutions in medicine who does research and provides guidelines, called the National Academies, really pulled together a group of experts to come up with specifically what are the needs and gaps in knowledge, and what do we need to do to improve survivorship care for patients who had received treatment for cancer. And this meeting and this project was done in 2006, trying to come up with specific guidelines and where to move the field forward. Where should research and advocacy and clinical efforts be put? And it's a shame that, as you can see here, really the title is From Cancer Patient to Cancer Survivor, Lost in Transition, which highlights what one of the big problems is, and its lack of coordination, and the fact that healthcare is extremely complicated and cancer treatment is even more complicated. You need surgeries, you need imaging studies, you get treatments done in infusion centers, radiation, pills, all sorts of medications and on top of that, to see primary care doctors, you may have to see a nutritionist, you may need physical therapy, you may need to follow up with surgeons. So it's quite complicated for any person to be able to handle this multiple appointments, and even more when you're actually feeling sick or feeling unwell from cancer itself or from the treatments that you've received. And that was really quite highlighted in this particular summary from the National Academies, in which people were working in silos between oncology care, primary care, surgeons, and others, and there was very little communication and partnership in trying to provide care for patients. It highlighted that providers lacked education. So oncologists, for example, lacked education on what are some of the issues and that normal persons get with aging. How do we screen for, or who should we be screening for high blood pressure, for high cholesterol, for having risk factors for heart disease, for thyroid? You do not want your oncologist doing half of those things because we have not done it for many years. And at the same time, similarly for things like getting, flu shots and vaccinations and your shingles shots, all of those things depend on and are mostly done by primary care doctors. And on the other hand, primary care doctors lack knowledge and education and training about how to care for patients who had survivor cancer diagnosis and who had gone through therapy. So they didn't know about long-term side effects of chemotherapy, or what to expect, or how are what cancers specifically we should be looking for and screening. And there were little resources and guidelines. So since then, a lot has been done, which I'll show you briefly and then go a little bit more into depth of what different areas of survivorship are, to try to improve how we provide care. So from that specific meeting and guideline summary, what came up? So people came up with what are the components that are key to specifically providing follow-up after somebody gets their treatment for cancer. And one of the key and number one priorities is trying to prevent recurrence, so coming back of the same cancer or developing another type of cancer, a subsequent one. The second part is preventing what are other side effects of chemotherapy, screening for cancer spread, assessing what the physical and psychosocial effects of treatments and of cancer can be on survivors, and coming up with interventions for those consequences. What are specific interventions that people need and do? So things to treat medical problems that can arise from treatment. So for example, women who undergo breast cancer surgery or gynecologic surgery, they have lymph nodes removed and may have chronic lymphedema, which is swelling of the extremities. They may have sexual dysfunction. So how do we treat those and how do we identify them? Similarly with pain, fatigue, and with the psychological distress that can happen to both cancer survivors, but also their family members and their caregivers. Another key component, which I'll mention briefly, is also related to what are the socioeconomical factors. So we know that a cancer diagnosis really puts a toll on people and can change all of your life in terms of specifically loss or changes of employment, insurance, finances, being on disability, and how can we provide services to support patients through it. And finally, like I mentioned before, really that coordination of care, which is key between specialists and primary care providers and supportive staff in clinics, so the needs of the patient are met. So here, as you can see, this is a graph on the left showing, so since that happened in the early 2000s, there's been a huge body of work really increasing in the area of survivorship. And this only goes to 2010 and has increased much more later, looking at how can we describe what are the side effects of and the needs of patients, and also provide interventions. So on this graph, it goes through different kinds of research, and the green ones are those that are randomized controlled trials, so interventions for survivors to improve specific quality of care, symptoms, and monitor those. And the majority of that research, unfortunately, well, not unfortunately, but the majority of it is done in breast cancer, which is here in blue. And I say unfortunately because I am a lung cancer doctor, like Dr. Aurora said before, and lung cancer, for example, is a disease that has huge implications in terms of survivorship and side effects and long-term effects from treatments like radiation and chemotherapy, and from smoking itself, which is a risk factor for lung cancer. There's huge stigma associated with it similarly. And yet we have very, very little data on what survivorship care is and what the needs of patients are. And what we do is extrapolate from all the great work that many researchers and physicians and patients have done and driven over the years in breast cancer or in prostate cancer, which are most common diseases and have big advocacy behind them and big collaborations and groups internationally to help support patients. So with all of that, now let's try to dive into specifically what are the different areas of cancer survivorship. And there are 4 specific buckets, to call it so. The first one on the top left, as you can see, is recurrence and new cancers. And that refers to, again, identifying whether the initial cancer diagnosis that somebody had returns or comes back, which is a recurrence, or if there's a development of a second type of cancer. And the risk and the chances of that occurring really vary and are very, very specific and change depending on the treatment, on age, on whether somebody has genetic risk factors from family history, carry mutations like BRCA or BRCA, which are common to increased risk of cancer. The second bucket are what are modifiable health behaviors that we as humans may have, which put us at higher risk. So things like smoking, drinking alcohol, being obese, diet. We know that if people modify their diet, for example, the risk of colon cancer is lower. Being exposed to or have chronic hepatitis and viral infections. So some types of hepatitis are related to developing liver cancer. HPV is related to developing cervical cancer, and some also cancers of the head and neck, like the mouth or tongue, larynx. So making sure that we address some of those modifiable health behaviors to again go to that pre-diagnosis stage that I showed you on one of the first slides and decrease the actual risk. The majority of survivorship care and what people think of when we talk about survivorship, though, goes into these two buckets on the right. One being long-term and late effects, so specific to treatment-related effects, and that those can be things that are during cancer treatment, things that are short-term after cancer treatment, and most commonly things that are long-term and can linger or be permanent. And then finally, also coordination of care, which is a huge part of what we also do, identified by that report from the National Academies, like I said, lost in transition, because this requires so much work and so many people to coordinate that it's very necessary for all of us to be on the work together. So I'll start briefly by talking about the risk of recurrence. And this is something that is very, very dependent on specifically the type of cancer, the stage in which it was diagnosed, what types of treatments people received or not. And recurrences can occur on the same place or site or in a different location. So for example, if somebody had a skin cancer removed in this area in which the surgery was done, there may be what we call a local recurrence, so on that same area, versus if you develop a different type, if you develop a skin cancer further apart on the same limb, then that may be considered to be a recurrence on the same cancer in a different location. In most cases, after somebody has completed their initial treatment of cancer, they go through surveillance period that commonly is 5 years. And after that, there are different types of recommendations that are dependent on the specific subtype of cancer that determine exactly how often people should be tested and screened for recurrence or for development of cancer. On most cases, though, after those 5 years, really, we do not screen with CT scans or with PET scans seeking for recurrence. We move towards what are regular screening tests that the common general population gets. So for example, if somebody is diagnosed with lung cancer and they receive a surgery or radiation for cure, after they've completed 5 years after that treatment, they move on into getting low dose CT scans of the chest that occur every year, which is the same guideline recommendation for screening that any other person who meets criteria based on smoking history would get. For colon cancer, similarly, you would get a screening colonoscopy after completing those 5 years. Depending on what they find is how often those would be, every 3 or 5 years. In breast cancer, similarly, we move into doing mammograms, which usually happen every year. And in some guidelines, there's recommendations to do them every other year. It really depends on the specific guideline that the institution goes by. At UCSF, we do yearly specifically. But what we know is that regardless of all of these guidelines existing, data has shown that actually surveillance is often suboptimal in people. And studies, for example, that were done in colon cancer survivors identify that only around 17% of people were receiving surveillance as recommended. So definitely a lot more to be done to make sure that people have adequate follow-up. Now, I mentioned before that there's also a risk of developing a different type of cancer, what we call a subsequent primary cancer. So this refers to, for example, if I am diagnosed with breast cancer and receive treatment, then in 10 years, if I am diagnosed with a new leukemia that is a type of blood cancer, that is a very different type of cancer. It's not the same one. And sometimes those diagnoses can be related to each other, which is what this specifically refers to. And that depends specifically on the type of cancer and what treatment people received. So for example, if you are somebody who as a child had Hodgkin's lymphoma, which is a type of cancer of the blood cells and the lymph nodes, which commonly get radiation to the chest that is on big fields, that can increase the risk of having breast cancer and of having cancers that are on that specific area in which a radiation was given. Like I mentioned before, if you are a woman who had breast cancer, or if you're somebody who had lung cancer and received certain types of chemotherapies, those can increase the risk of developing blood cancers in the future. That really depends on what type of chemotherapy was given, what doses were given, and that's a risk that commonly goes down over time, but that does exist. And the other part is whether or not somebody, for example, received a transplant and are on immunosuppressants, and which are medications that decrease their immune system, then they're a higher risk of developing things like skin cancer and other types of cancer. And in addition to that, still lifestyle factors and things like smoking, obesity, and alcohol can increase the risk of having another type of cancer. So if somebody is diagnosed with lung cancer but has smoked or continues to smoke, they're still going to be at risk of developing other cancers that are related to smoking, which are things like bladder cancer or cancers of the head and neck, of the larynx, of the tongue, etc. And finally, genetic specific factors. Like I alluded to earlier, there are certain genes like BRCA and leishmania and other specific traits that are associated with higher risk of cancers because our genetic materials and the repair mechanisms of our body that help us fix our DNA can be damaged. And that makes certain people at higher risk of developing different types of cancer. So they may have had one specific cancer at the beginning, and then many years later develop a second different one. An example of that, for example, are women who have breast cancer related to BRCA and then develop GYN specific cancers like ovarian. And there's specific recommendations and clinics that really provide guidance on people who have those genetic risk factors on how to give screening and surveillance. So at UCSF, we do have a high-risk genetics clinic that anybody who has one of these mutations in their family or who is concerned that they may have it should reach out to their doctor to be connected with. Among all the subsequent primary cancers, lung cancer accounts for the majority of it, around 19%. Other common ones are breast among women and prostate among men, who are again the most common that occur over time. And in people of course, cancer is a disease of aging. So as we get older, the risk increases, and common cancers that may happen with aging also are going to be something to be at risk for. In terms of how to screen for this different types of different cancers that can happen subsequently after first cancer, that really depends. So normal patients should follow the normal guidelines for screening that apply to the general population. But in addition to that, there's specific screening that can happen for subsequent primaries. So for example, for women who had received radiation to the chest, as I mentioned, like in Hodgkin's lymphoma and in esophageal cancers and lung cancers and breast cancers, there are recommendations to get annually mammograms and sometimes also MRIs, depending on whether that happened at an earlier age or not. So that's something definitely that exists because there's a known increased risk of potentially having breast cancer. Similarly, for children and young teenagers and people who at a young age receive radiation to the pelvis or to the abdomen, to the belly, or to the back and spine, there are recommendations to start with colonoscopies to screen for colon cancer at the age of 30. Again, for those with radiation to the chest and axilla and other areas in the upper body, there's recommendations for lung cancer screening with doing CTs of the chest, and also on patients who have had brain radiation during a young age, there is recommendations for getting surveillance with MRIs to identify if there's the development of any cancer in the brain or the central nervous system. Now, moving into specifics of what most of survivorship care focuses on, and you've probably heard about, are related to monitoring long-term side effects of treatment. And here, this picture is showing what basically are all, and not all, but many of what the potential long-term effects of chemotherapies and treatments are. And those effects vary by person. So not every person will get them. They vary a lot by the specific treatments that people received, and they vary a lot also by how long did you receive those treatments. Now, with the development of newer and newer types of treatments like immunotherapies, like targeted therapies, like cellular therapies, like CAR-Ts and others, what this picture looks like is very different. And we're going to continue to see this field of survivorship care expand into niches that are very specific to each of the different types of cancer and types of treatments. And the next 3 slides, this one included, I apologize, are going to be dense with very small letters, but it has the purpose specifically is to highlight how diverse all of these late effects can be and how dependent they are of whether they're from chemotherapy agents or from radiation and others, and can vary and really affect anywhere in the body. So common things I'm going to highlight are things like cardiac disease and cardiac complications that can happen after chemotherapy or radiation, and that is something to be quite aware of. So for example, certain chemotherapies that are called anthracyclines and agents against HER2 like trastuzumab are commonly used on breast cancer, can have long-term side effects of patients developing cardiomyopathy or difficulty or dysfunction in how their heart pumps. So that is something that both oncologists and primary care doctors have to be cognizant and know about, so we can identify even if somebody develops that complication 5-10 years later. Radiation therapy to the chest can also cause complications in the cardiac system, in the cardiovascular system, like developing fluids surrounding the heart, like pericardial effusions, inflammation, which is pericarditis, and also developing coronary artery disease or plaques, which we know and most people know of are mostly related to diet and high cholesterol and other things. Well, also inflammation from radiation can cause it. There's lung toxicities that can occur with scarring of the lungs and having inflammation of the lungs. There's also complications to the nervous system that are related. For example, things like peripheral neuropathy, which is numbness and tingling of the hands and feet related to nerve damage, cognitive impairment, and I'll talk a little bit more about those. Blood-specific disorders, like I mentioned before, and organ damage. So things like your kidneys, your kidney function, specific to the bladder. There's different changes on how the liver works or related to absorption of foods in the gut and bowel. There can be changes to hormones. If, for example, somebody received radiation to the neck, then their thyroid gland may not be able to function and provide thyroid hormone as commonly. And certain drugs like immunotherapies are also associated with different dysfunction of the thyroid gland, of the pancreas, and others. And this list I know looks very scary because it's so long, but the rates in which this happen and to whom they happen vary significantly dependent on types of treatment, specific cancer that the patient had, for how long they had their treatment. And some of them are things that are common and that we see, like fatigue or having, rash with certain types of treatments. And others are things that are very rare and that we don't see quite commonly, but for the sake of completeness are listed here. And then in this last slide, there's also issues related to our fertility and to sexual dysfunction that are related to the treatments of cancer. And many cancer treatments can impair fertility and cause sterility. And for example, early menopause in women who receive treatments for breast cancer, which we're trying to decrease the levels of hormones that can promote cancer growth. So we're going to talk a little bit about what are some of the most common side effects and how are those treated. And this is, again, a very, 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 very broad strokes and superficial of how of what some of the common side effects are and what common treatments are. So I'm happy to answer specific questions and provide resources later on for more detailed information. But something that is the most common complaint during treatment and after can be fatigue. And this, it's really dependent on the person and how it's described, and of course the severity. It can be described as something as I just wake up a little bit later in the mornings, to I take a 15-minute nap in the afternoon, to during cancer treatment, some people are more tired and may need to rest in bed or in a chair for a couple hours a day. And the causes really can be anything from cancer itself during that initial stage of treatment and diagnosis, to related to radiation, to chemotherapy, or to other medications that you're getting for side effects. So for example, medicines that may be given for insomnia or for depression, for anxiety, may cause sedation. It may make people sleepy and they may feel more tired or more fatigued. There's no magical pill or solution really on how to treat this. Taking naps when you need them is the number one, I think, ideal way to treat it, and trying to really modify lifestyle with things like doing some degree of exercise every day and physical activity, and trying to eat a healthy diet to try to improve really the level of energy and stamina that people have, and build onto that stamina over time as we are farther along from having a cancer, from receiving a treatment for cancer. If fatigue is a side effect or a something that is seen because or caused by depression or psychological effects of dealing with a cancer diagnosis, then looking for help with counseling and or taking antidepressants is something that definitely can help. The other very common effect that we see is neuropathy, which I alluded to earlier, and that can refer to numbness and tingling, which some people describe as pins and needles, or feeling ants that are walking in on the tips of their toes or fingers, to pain. And it depends on the degree of how much nerve damage there has been. And it's something that can be limited to tips of fingers and toes, or progress and involve the whole hand or the whole foot and lead to loss of sensation. And that, again, it's really dependent on what treatments are given, for how long, is it caught earlier or not, and are there other things that can also cause neuropathy that are adding to that nerve damage. So for example, diabetes is a very common condition that causes neuropathy to begin with. So if somebody has long-standing diabetes and has neuropathy from diabetes and then gets chemotherapy, probably that neuropathy is going to get worse. With certain treatments, and for the majority, usually neuropathy improves and resolves over time, but that can take time, so months or sometimes years, and in some cases it can be permanent. So what are some of the treatments? Avoiding cold, which can exacerbate neuropathy. So patients may feel more pain if they are, grabbing a cold drink or drinking cold water. Taking medications. There's certain types of medicines which are written here, like gabapentin and Effexor, who really treat nerve pain, and who you can talk to your primary care doctor and to your oncologist about. And there's certain alternative treatments. So for example, use of cannabinoids in terms of CBD oils and creams have been shown to be effective, using acupuncture, and then exercise, similarly trying to improve blood flow, and in that way improve some of that nerve conduction. Pain is another effect that we see commonly. This is more of one of those short-term acute side effects, which is most often seen after surgery or after radiation. And it depends specifically on the type of treatment, whether this is, for example, a nerve-related pain similar to neuropathy. If somebody had surgery and nerves were cut during that initial surgery, which can happen, or if it's related to specifically cancer or other things that can cause different types of pain. Pain is treated very broadly, as many of you know, and really depends on what the cause is. So if we think it's something inflammatory, we use anti-inflammatories, which are called NSAIDs. So things like ibuprofen or naproxen. Opiates sometimes are necessary. Other types of pain may be treated with Tylenol and acetaminophen, or others may require nerve pain medications like the ones I mentioned before, like gabapentin or Effexor and others. So in reality, treatment of pain is very specific depending on the type of person and the type of procedure and where the pain is coming from, but something that requires long-term discussion with your providers and with your care team. Lymphedema, which I also mentioned briefly before, is another major area in which survivorship focuses, primarily seen in women with breast cancer. And again, it's like I explained earlier, it's driven by the removal of lymph nodes during surgery. So these lymph nodes are part of our immune system, and they really help drain our body. And they are like small threads and vessels that help drain fluid and blood from our system. So when those are removed, sometimes that fluid can be, that fluid drainage is impaired and can accumulate in different areas of our body. So For example, it's common to see in breast cancer clinics or survivorship clinics, women who may have swelling of one arm and not the other. So that most commonly would be related to lymphedema. And that swelling, of course, as you can imagine, can cause discomfort and pain, and sometimes leads to skin breakage, which can be infected. And for it, really, treatments that are key are trying to identify it earlier, to give physical therapy, massages. There are lymphatic massages and drainage that are things that patients can get and that also are taught to them in different lymphedema programs. And the use of compression garments that can help with trying to prevent some of the fluid buildup and bring that back. Hot flashes and early menopause is another big area, which is something we see commonly, and both hot flashes can occur in men and women, depending on the specific type of cancer treatment, and early menopause in women. And this can be related to surgery, to certain chemotherapies, or like I mentioned before, to hormone treatments. So commonly men with prostate cancer and women with breast cancer receive hormonal therapies that are specific and used to decrease the levels of estrogen and testosterone on the body, depending, of men or women. And the role of those is try to prevent cancer growth and to aid in treating the cancer. But by causing dysregulation in our hormones that our body is used to, can definitely cause hot flashes that can be quite disturbing to people and to your regular life. So ways to treat those can be either, again, with types of medications, or we try first, to change what type of clothing people are wearing, to make sure that you're hydrated, to include showering throughout the day so you're more comfortable, and then the use of acupuncture and other specific alternative treatments. From early menopause, there's other long-term effects that can happen. For example, it can weaken your bones and cause osteoporosis. So that is something that on women who are receiving cancer, specific treatments that can trigger menopause and lead to not having periods earlier on, we want to know. So we can screen for osteoporosis, so we can start supplementing with medications to strengthen bones, so we can talk about diet modifications and taking supplements like calcium and vitamin D. Another quite common specific complication is sexual dysfunction, and that can range from having decreased sexual drive, which can be physical or psychological, or actual dysfunction during penetration related to, for example, vaginal dryness or atrophy, or developing pain with intercourse from similarly changes in hormones from the treatments. And there are multiple specific types of treatments that can be done by using moisturizers, lubricants, and discussing, counseling sessions too. Something that many people have heard about, and that is another big problem, is having cognitive changes or changes on how we think, and that varies a lot depending on the person. It can be something as notable as having changes on the rate of how fast you speak, to some people having very, very minimal changes, but that are noticeable to them. For example, I had a patient who was used to always doing their taxes, and they were, very and they were a high functioning person, very independent, and really noticed after years of treatment, when they went back to doing their taxes, they could not do them. something that was very simple or that they were doing in the past all the time became burdensome. It was hard to concentrate. It was hard to come up with the math and the numbers. And that was the first time years later that they had noticed that they had some changes on the way which they thought, their cognition after their treatment. And on a regular day-to-day basis, otherwise they notice absolutely no difference. So this chemo brain or the cognitive changes most commonly happen during treatment and get better with time. But in some cases, it can be long-term. And we can see for longer years changes that people experience that can be things as even having insomnia, not being able to sleep. Quite common in patients who had brain tumors and received radiation to the brain, less common in other types of cancer, although as you can see here, that says 17 to 75% of patients with breast cancer, the data is everywhere. And really depends on who do you ask, when do you ask, how do you ask it? And of course, every patient has a completely different experience on how they may feel their body and experience side effects that we need to individualize for the person. Treatments are combination really of both behavioral therapies and pharmacological treatments. So behavioral therapies are things like improving the way you sleep, making sure that we go into routines of exercising, of eating well, of decreasing stress, of doing lists to keep up with tasks, of going to psychotherapy. And then pharmacologic interventions that are specific to pills are something that also has been shown to be effective. And similarly depends on how severe it is when people are experiencing it. Now, one of the most common things that I can, of course, not mention is the psychological effects that cancer and treatment can have. And those, specifically depression and anxiety, are the most common and really are driven by the severity of how serious having a diagnosis of cancer can be and how difficult it is to face the unknown of, am I going to die of this cancer? Am I going to be cured? Is it ever going to come back? And all of those things can cause real fear and anxiety in people. It can show up as anything like it's not able to sleep, being less hungry, feeling a lot more fatigue, or your more classical presentations that we think of depression, like feeling sad or tearful. And in terms of how to treat it, sometimes prescription medicine is needed, either short-term or long-term. Psychotherapy and counseling is definitely, I think, highly recommended, and really seeking for support. So one of the highlights of this new era of social media, of the internet, and on being on platforms like this one, like Zoom, is that it really provides community and increases accessibility of people to connecting with other survivors who may be going by the exact same issues and unknowns and anxieties that you are as a human being. And being able to share and be heard and really understand what others are going through, I think has a lot of value. So I would encourage anyone to seek, whether it's online or in person or Zoom-based support groups if they're interested on it, to connect with other survivors. Many times it is and can be very challenging to feel that you have a new diagnosis that is life-threatening. You're going to treatment. You may have some long-term effects after this treatment, and not feel like you're a burden to your family, or feel like you cannot speak to your family about it because you're scared that they may get sad or they don't understand what you're going through. And sometimes family members do understand and they want to also be able to engage with you. And all of these dynamics are very specific and complicated. And I think seeking support and counseling is really key in terms of providing support care. And lastly, one of the most common effects that unfortunately we see throughout a cancer diagnosis is the financial aspect. That is something that we call financial toxicity. And it's really the impact that having a cancer diagnosis can have on somebody. And it comes from high cost of care. And even if you have great insurance and have no co-pays, most people, their day-to-day life is affected. They may not be able to work, or their family members have to take time off work. You may need to find care for your children while you're getting treatment. You may need to travel long distances to get specific treatment or to go into a clinical trial. And all of these things compound in terms of cost for people. And there's data showing, of course, also the effects in terms of gain income that is lost on people that are diagnosed with cancer at a very early age and need to go on disability and lose years of being able to work and be productive. It's estimated that 2 in 3 people who are diagnosed with cancer may experience financial burden and toxicity of the cancer diagnosis. 25% of survivors report that they use all or most of their savings during cancer treatment. And of course, having that increased financial stress is associated with increased rates of depression and anxiety and distress, and can affect quality of life, which is key throughout all of these in terms of our well-being. So there are different types of supportive resources that are not sufficient, I do not want to lie, but that are available in terms of financial navigation, nonprofit organizations, transportation support that are available. So for anyone who is experiencing this or going through treatment or knows somebody who is, make sure that they feel that they're connected and can ask to be connected to social workers, financial advisors, and others to try to come up with what are some of the alternatives that exist from different resources. Now, moving into the last piece is preventive care. And we've talked a lot about side effects and long-term effects. We talked about risk of recurrence. And now, what are other things that we can do to actually decrease the potential risk of a new cancer developing or cancer coming back? And there's 3 main categories really here. One is diet and physical activity. The second is smoking cessation and avoiding tobacco products for those who smoke, and limiting the consumption of alcohol. Alcohol and smoking cessation are both known to be carcinogens and can cause cancer, both from exposure long-term to tobacco products. And it's known that when somebody stops smoking, the more years they're out of smoking, their risk of cancer from tobacco decreases over time. So definitely, calling quit lines, going into support groups, using nicotine replacement products. There's new therapies that are pill-based that also help, is very, very important. And in terms of limiting the degree of alcohol that is consumed, similarly, either avoiding or limiting to less than 1 drink a day is something also that helps in terms of decreasing that risk. Now, for physical activity, these are things that are probably going to sound obvious, but exercise is associated with improving survival and patient-reported outcomes in most cancer survivors. So what does that mean? It means that people who exercise regularly live longer. And this has been shown in different types of cancer. Most of this data comes from the breast cancer world, like I showed on that one of those first graphs. But exercise also improves your quality of life, can improve mood, can decrease distress, and is something that definitely physical activity is recommended. Does that mean that we expect that everybody's going to go run a marathon? No. So what we're hoping is that over time, people can build up resistance and increase the amount of exercise that they're doing. So what does that mean? It means the goal is to be able to do 30 minutes of a moderate intensity exercise activity per day, which are 150 minutes. So something like power walking or dancing, biking would count as this, or 75 minutes over a week if you're doing a more vigorous exercise. It's recommended that people also do resistance training to build muscle mass also if they can. And again, this depends specifically on the types of your baseline physical activity, of your age, of how physically active you are, and how can you build towards those goals. I would say there are a lot of excitement also on trying to bring physical therapy as a tool to improve physical activity along the cancer survivorship continuum. There are studies looking at something called pre-rehabilitation. So giving people who are going to go, for example, to surgery, physical therapy before, so they get stronger, and see if that way they feel better and have less complications after surgery. We hope that there's similar studies going through chemotherapy and treatments in the future, and also the use of rehabilitation after, again, with exercising and trying to improve strength. And then with this, similarly looking at maintaining a healthy weight, which I'll talk more in a second. So what are the benefits? I talked about this already a little bit, but physical activity has been shown to reduce fatigue, which we talked earlier about is one of the main long-term effects and acute effects of cancer and cancer treatments. It can improve quality of life, and then improves, of course, fitness and our ability to function. Now, in terms of diet and weight, the goal is to decrease the rates of obesity and try to maintain a BMI that is of less than your ideal weight based on size and height. And the reason is because having a high BMI and being obese, a BMI of more than 30, has been shown to increase the risk of dying of cancer in patients who have early stage breast cancer and endometrial cancers. And similarly, for having BMIs over 35, in some studies has been shown to potentially also increase the risk of bad effects in prostate cancer and colon cancer. So what are diet recommendations? And diet can be by itself a 2-hour lecture because there's tons of myths and tons of different diets that people can follow, recommend, read about. I would definitely say to consider asking to speak with our nutrition center at the nutritionist at the cancer center, or with the OSHA center, which are give us complementary and alternative treatments. But in broad strokes, and thinking about what are common things that are recommended in terms of trying to follow a diet that promotes a healthy lifestyle and leads to reducing the risk of cancer and risk of death, is increasing fruit and vegetables, limiting or avoiding red meats, decreasing fat intake, and limiting alcohol, like I talked before. Following a Mediterranean kind of diet pattern has been shown to lower the risk of dying of cancer in certain larger studies, like in prostate, like in patients with prostate cancer. So using things that are rich in olive oil or nuts or fish and whole grains has been shown in certain studies to be beneficial. These, of course, are not the data is of associations. Doesn't mean that if somebody who has end-stage cancer changes their diet, that's going to change their outcome or cure the cancer. That is unlikely. But by having a healthy lifestyle with doing exercise and improving your diet, you are decreasing inflammation, and you are decreasing other things that happen with age that can cause complications and increase mortality, like having high cholesterol and developing hypertension and kidney disease, that still patients who have cancer and who are survivors can get, like every other person. Now, here are some resources, and we'll make sure that more of those are online that have guidelines specifically with more detail about diet and specific exercise that come from the American Cancer Society. And to wrap up, I've talked a lot over the last hour, and I think have shown you how complicated the care and multifaceted of a patient who has been diagnosed with cancer, who's undergoing cancer treatment, and then moves into this survivorship or surveillance stage can be. And really, the key is to try to make sure that we are not still lost in transition, like that report from 2006 showed, but that we develop more team focused approaches. So what has been done over this last 15 plus years is to really come up with solutions to identify how can we partner with other doctors and other healthcare staff to provide comprehensive care for patients and survivors. So that means many times co-managing, so having an oncologist and a primary care doctor work together. Again, they have different areas of expertise that are complementary. So being able as an oncologist to know what the long-term effects of chemotherapy and things that patient may be at risk are is helpful to a primary care doctor who is able to then help identify, what are other things that we should be screening for, how to treat your insomnia, how to manage what some vaccines that people are missing are. That has led to the development of multidisciplinary clinics, so clinics that are specific to survivorship care that provide long-term follow-up and that are similarly shared between teams of primary care doctors, of oncologists, of nurse practitioners, of PAs, and other providers who have case managers and have social workers that are able to patient navigators that help people coordinate all this care, provide the support services that you may need, like transportation or disability or insurance. May be able to identify, whether there are other needs like physical therapy that patients may have, and trying to provide this more comprehensive care. Another part that has been added to this survivorship care is the introduction of something called survivorship care plans, which some people here may know and be aware of, which are more of a similar to a summary of what your specific treatment has been that you've completed and what are the recommendations of next steps. And that is a document that commonly is given through patients once they complete their oncology and cancer clinic aspect of treatment as they move into the primary care world to be able to serve as connection between the primary care doctor and oncologists of what is the roadmap of what your future should look like, what things to look for, what types of supportive care of screening tests are needed. So lots and lots of interesting things happening in this space, lots of more things that we need to do better and discover and partner with patients to actually learn more about the experience and know how we can best provide support care. And with that, I'll thank you all so much for your time, for listening, and I'm happy to take any questions.
Thank you so much, Dr. Velázquez Mañana, on this really important topic of what happens after cancer diagnosis, especially on cancer surveillance and survivorship. And I think you really covered excellent subtopics today that come up in the day-to-day practice and care of people who have had cancer diagnoses. I'll start with sending you a question, Dr. Velázquez Mañana. I also wanted to mention that I really liked your earlier quote stating that survivorship spans the cancer journey. All right, so my first question is, when is someone considered a cancer survivor?
I think since diagnosis, I think that when when we look, if people go online and look at historically what survivors have been labeled or called, it's after somebody is, free of cancer for X amount of years, which commonly 5 is the number. I think that is exclusionary of the experience of many of our patients. And I think that we should not be labeling people diagnosed with cancer as a cancer patient, but rather you're living and you're thriving. And that's our goal, even if it is through treatments that may not make you feel that well, is how do we support people through that journey and make sure that they are, living the best life that they potentially can at that different stage and build towards the future.
Yeah, I think it's really important. I agree to shift the way that we term things to say a person with cancer rather than the opposite. Another question is, how does a person find a survivorship program if, say, they are not a patient at UCSF?
Yes. So there's a couple ways. One is that I would ask your oncology clinic is the number one, the first way in which I would go about it. If they have a survivorship clinic or not, or any resources specific to survivorship. Many academic centers and many cancer centers that are not in universities will have a survivorship clinic. If that is not the case, there are different venues to identify those. One is there is the national I'm forgetting what it stands for, but there's a national network of survivors that is driven by patient advocacy that has a lot of different foundations and nonprofits listed online and their resources. And many of these things have resources available over the phone, over the internet, now on Zoom. And also there's local nonprofits and groups that can help identify, support groups, patient navigators, and other resources that may exist that provide at least the psychosocial support aspect. So for example, in the city of San Francisco, there is, depending on the area, the language you speak, the demographics that you identify with, different types of foundations and organizations that provide that care.
Yeah, I'm so thankful that they exist all, with just a click on the keyboard. I'm looking on Google. And just to kind of back up that same question is, when should a person with cancer find a support group? I know you touched on support groups a little bit, and I think that I wanted to add on about what are tips that you might have about participating in support groups?
So that is, I think it depends specifically on the person. I would say the data surrounding support groups actually shows that, unfortunately, patients with cancer engage in support groups less than other types of chronic illnesses. So for example, things, like having diabetes or chronic kidney disease and being on dialysis, or having substance abuse issues like alcoholism. Like, we all think of support groups and think AA. Well, no, many other types of support groups exist. I think depending on how we define them, do we define blogs and groups online as support groups, then probably the engagement of patients with cancer is a little bit higher. But on those who are in person attending, tends to be slightly lower than for other illnesses. The benefits, I think, are, numerous. One, you are getting to know other people who are going through the same illness and through the same steps and path. You're able to identify resources through them. People talk to each other in a support group. It's same as you talk to each other on a waiting room or an infusion center, and you hear about, what kinds of therapies they're getting. Are they on a clinical trial or not? What their experience is. Did they get referred to rehab or to see a nutritionist? And that provides a lot of empowerment. And I think the more you know and the more you're able to share experiences, then you're able to go back to your doctor, to your oncologist, to your primary team and ask, well, I heard or learned from this person that there are these resources that exist. How can I get those, or should I get those? And I think there's so much power that comes from patients being able to ask any question that they want, to have the knowledge to be able to ask those kinds of questions. And because unfortunately in our current healthcare system, time is limited, and doctors like ourselves many times have 15, 20 minutes, 30 minutes to see somebody, we're not able to address everything. And many patients will tell me, my doctor has an agenda and this is what they're talking about, and then we're done, and they don't take the time to explain all of those things. So as I said this and talk about empowerment, part of me feels that the burden should not be in the patient to be asking for anything, and we should be giving it to everyone. But as somebody who knows the reality of what happens on the day-to-day basis, I still believe that we are not there. I hope that we are someday. And that's why speaking with others, seeking for support, getting to talk to people who are going through things like you, it's very helpful. And the last point I would make about support groups is I know a little bit about them, as you can see, because I actually have done research on it and worked with a support group of Spanish-speaking patients at the institution in which I work. And there's people who have been attending that support group for 20 years. So when we interview them and talk to them and you sit down and listen to their stories, they are family. They have a bond that nobody else has and can understand. And it's very hard to describe that. And, I can speak to it, but I think that nothing speaks louder than if somebody keeps going to the same place to meet people who loses friends there, who unfortunately die of age or cancer, who meets new friends and still 20 years later shows up, there's clearly some degree of benefit that drives coming back.
Thank you for that really thorough answer. I just another small piggyback to a similar question is that when there are not a lot of resources close by, especially for things like mental and nutritional health, are there any apps or programs that you recommend people to download and use to help them, maybe not so much with support groups, but for nutritional or mental health itself?
There are definitely apps for mental health. There are different studies also looking at implementing apps for meditation, for mindfulness, for doing exercises. It depends specifically if most of them are either for pay or accessible through clinical trials. So it's something that I would look for at the same time, because I think there's benefit. And there are organizations and national support groups for cancer survivors that are specific to usually types of diseases, so breast cancer, prostate cancer, esophageal, you name it, or the Survivors Network that have 1-800, for example, phone numbers in which you can call nationally from anywhere and be connected with services either around you or phone specific counseling and phone specific support groups too. So all of those things exist. It's more of how to be connected. I mentioned the Cancer Survivors National Network is one, and then the American Cancer Society is another great resource in which on their website, they have a list also and connections based on region on where can you get access to these kinds of services.
Thank you. So just shifting gears a little bit, a question is, when can a person do normal things like go back to work or travel?
That's a hard question. And that really, it depends on where you are on your cancer journey and what kinds of treatments and disease do you have. So as I said earlier, I treat lung cancer patients. I have patients who are working every day throughout their treatment, having metastatic disease or stage 4 disease and getting immunotherapy, targeted therapies, sometimes even with chemotherapy. So it really depends. There are other types of treatments, or for example, people who have blood cancers that may need a transplant, in which they are going to be debilitated or be immunocompromised and at risk of infections for a long period of time that may not allow them to go to work. So all of that is something that the patients need to discuss with their cancer doctor, and that is very specific to the treatments that they're getting, the cancer that they were diagnosed, the type of cancer, and how do they feel. I'm at the same time, I would say, a great advocate for traveling. And that is something that if patients have planned trips to see their families, is something that I think it's, important to do also.
I'm glad you mentioned that, that it's not a one size fits all answer, that it don't have to wait till some certain standpoint, and that it's important to live throughout this journey. Another question just came through asking, what is the cancer recurrence rate for breast cancer survivors within 5 years and after 5 years? And do you foresee a time when there is a test to confirm cancer survivor is cancer free?
Okay, so for the first question of recurrence risk, it really depends on multiple factors. One being what stage the cancer was diagnosed at, so how extensive it was. And usually the risk is lower for earlier stages of cancer and increases as the stages advance. So for example, for stage 1, which is the smallest of the stages, it's somewhere around 7%, 5 to 7%. And for stage 3, more in the realm of like 10 to 15%. That being said, those are very generic numbers and terms and depend on a lot of other factors. So breast cancer is a disease that has multiple subtypes. So whether people are hormone positive, HER2, something positive, or none of those, which is something called triple negative disease that tends to be more aggressive. So the rates of recurrence are very different depending on whether you have triple negative disease versus you have one of the other ones, and other risk factors that may be on the specific pathology. So something that on broad strokes is around the numbers that I gave, but again, depending on the specific case. And then the second question was, do you foresee a time when there is a test to confirm cancer survivor is cancer free? That is really hard. I hope so. I think that in the future, we are probably going to move more and more towards doing blood-based tests that are able to identify cancer sooner and see if there's smaller cancer cells that are circulating in our bloodstream that we cannot see on imaging. There are certain clinical trials on different diseases and studies ongoing, trying to identify if, for example, looking for those little blood cells, something called minimal residual disease, after somebody has surgery for cancer or gets treatment, impacts the likelihood of developing cancer again in the future. How long do they live or not? And all of those are ongoing, are not something that right now we have across the board, but I think that at the speed in which science is advancing and discovery, there's a lot of excitement to potentially see those things in the future.
Absolutely. And that was a nice little teaser for our next session for next week. I have 2 more questions for you, and I know we're short on time, so I think I'll just ask one of them. How should I deal with anxiety about the cancer coming back, coming from the perspective of a patient who, has now completed their treatment for cancer care?
That is really hard. I think that seeking support is important. And there are certain studies looking at the use of psychotherapy, meditation, yoga, acupuncture, and different mindfulness specific approaches to trying to decrease that anxiety. So different types of, there are studies surrounding it. And for example, in the Osher Center here at UCSF, we do have acupuncture, yoga, and meditation courses and classes that people can attend that definitely help with those.
Thank you so much, Dr. Velázquez Mañana. And with that, we're right on time. I think I'll close out the session. So thank you everyone so much for participating today, and thank you for your questions.